This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Direct primary care is an innovative alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story Podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Maryal Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care to me is a system where I can provide the kind of care I really want to my patients that is personalized to them, where I have time to think about and research what's the best treatment for them and follow up and do all the things that we're supposed to do in primary care, but our current system doesn't allow us to do. For me, it's the most rational way to do primary care. My name is Erika Bliss, and this is My DPC Story.
Dr. Erika Bliss is a graduate of the University of California, San Diego School of Medicine. She received her undergraduate degree in history from San Francisco State University and a master's degree in Latin American Studies from Stanford. She completed her medical training at the Swedish Family Medicine Residency Program in Seattle in 2003. After residency, she worked at Carolyn Downs Family Medical Center in Seattle, an FQHC, where she served as a staff physician, clinical site director, and director of clinical quality. Dr. Bliss has traveled extensively in Mexico and Central America. There, she collaborated with a local women's health and human rights group to do research, including a video project on domestic violence. In addition, she developed and implemented a medical education exchange program with a rural hospital in Honduras. While in medical school, Dr. Bliss was a founding member of the Free Clinic Project of San Diego, a student-run project that delivers primary care to homeless and indigent people. Not only has Dr. Bliss focused on direct patient care, she has also been involved in organized medicine and health policy through her work with the American Academy of Family Physicians. Additionally, she served on the Education Task Force for the Future of Family Medicine Project, a national effort to chart the direction of family medicine for future decades. Dr. Bliss served on the boards of the Washington Academy of Family Physicians and the American Board of Family Medicine. Dr. Bliss helped found and later served as CEO of Qliance, the first large-scale DPC organization in the U.S. started in 2007. After Qliance closed in 2017, she established Equinox Primary Care, where she is a solo practitioner. She also volunteers for End of Life Washington, helping people who want to take medications to aid in dying to avail themselves of the Washington Death with Dignity law. She has conducted volunteer forensic medical exams for asylum seekers since 2005. And since the beginning of COVID, with access to abortion severely curtailed, she has been providing telemedicine medication abortion services. Outside of medicine, she is a busy person, lately helping take care of her granddaughter and spending time with family, as well as raising her 1-year-old miniature poodle, Shaytun, who she hopes will become a therapy dog in her clinic soon. Welcome to the podcast, Dr. Bliss.
Hi, nice to be here.
Thank you so much for joining us. I just am so honored to have you as our first interview of the season. And when I say that, what I think about is that you've really been there and done that and seen it all. You have gone from residency to an FQHC to working at Qliance, being CEO there, and then opening your own direct primary care at Equinox. So thank you so much for joining us today. Now, in the past, you had said a quote that I really loved, and I wanted to start our conversation with that. And the quote was, "And that's what primary care is. It's meant to adapt to, figure out, and help the communities it serves." And so I was wondering if you could share with us what that quote means to you when you show up for your patients every day.
So that quote was really from some of my most important mentors going into family medicine. So really kind of more specific to the specialty of family medicine, but talking about being the primary care doctor for your community. And to me, it represents some of the best of the specialty, some of the best of primary care, and reflects actually data from the rest of the world in other healthcare systems where primary care is the foundation of the healthcare system in any community. So that always really appealed to me. And then in family medicine, the training is so fabulous for walking into any community and adapting to it. That's really what it's all about. So for me, family medicine and as a system and approach for doing primary care, which is a function in the healthcare system, was the ideal. So from early on, I was talking to my mentors, and that's what I was hearing over and over again. And examples of that are, I work in a large metropolitan city in Seattle. So it's not like I'm going to learn how to undo colonoscopies. We have a ton of people here who can do them. They do them all the time. They're excellent at them. So I'm not going to do that. But what if I was a doctor in a very small community and the only way that people could get colonoscopies consistently would be if I learned how to do it? Well, it's a procedure. It's something that as a physician or any well-trained healthcare provider, you can learn to do any procedure. It takes some time and focus and all that. But if that's what your community needs, you do it. If your community needs you to do, we've all learned about contact tracing now, right? In public health and epidemiology type of work, then that's what you do. If you have a heavy load of substance abuse disorders in your community, then you learn to work with people who have that issue. So to me, that wasn't specific to DPC. It was really about what are we supposed to be doing as primary care providers, whatever type, in any community. So then translate that to DPC. I felt frustrated with the system before I started doing direct primary care and realized that direct primary care, by creating a rational business model, would allow me and the folks that did this to function in a way where we could adapt what we do to the community. So you could, whoever signed up for your practice, whatever populations you ended up serving, you study that and you observe and you research it and you figure out what do those folks need. It's 100 times easier in DPC because you have control over how you spend your time and resources.
Absolutely. And I think that it's such a testament as to why this movement is growing and continuing to grow like wildfire, because we're not cookie cutter doctors and we are not working with cookie cutter patients. And so the ability, like you said so eloquently, to learn and to, study about your patients and then to deliver that personalized care every day to your patients, it really is so different from every 15 minutes, you have a new appointment.
Exactly.
Yeah. Now, I would really love to also have you touch on your experience overseas, because clearly you were so involved working overseas in a health setting. What of your experience there have you also been able to bring back to your practice at Qliance, but also especially at Equinox now?
Yeah, so probably the most influential experience for me, and this was a big part of what made me decide I wanted to go into medicine, was working with the Women's Domestic Violence and Human Rights Organization in southern Mexico, in Chiapas. I went there as a graduate student doing Latin American studies with a background in history, looking to volunteer with them and write my thesis about their group and their movement, because it was so striking that such a progressive and incredibly well thought out program had developed in this pretty remote part of Mexico. Or it's a big travel destination, but it's a very conservative part of the country. So I interviewed all the people working for the organization, all incredible women and activists. And funny enough, the doctors ended up capturing my imagination more than anything. And I realized healthcare was a really interesting way to access a community and find out what was going on. You have this very privileged view into the private lives of people in a community that it's hard to get. You have to be like a priest or a doctor to hear those kinds of stories. What really struck me about the doctors too was two things. One was their really very well developed concept of public health, community health, and empowering communities to take control of their health. The other was their incredible humanity in dealing with patients. They would see women who had never been to a doctor before, who had been sexually and physically abused. Many of them had terrible reproductive health problems that were never getting addressed. So this was their first time. And I just sat in the room with them while they did these interviews with these women. And I was so impressed with they were so relaxed, first of all. And it was, we can take all the time we need. And when you want to stop, we stop. And we can always do another appointment. So there wasn't this concept of, I have to meet my metrics. This woman needs a pap smear. She might have cervical cancer. I better get it done now. It was more like, I need to gain your trust. So we'll do this at your pace. And they were very well informed about, they were doing the trauma focused approach to women's healthcare and general mental health care long before. And this was 1992, basically, that I was down there working with them. So way ahead of where we were. So that really struck me, and it planted a seed. So when I went back to school and I realized I wanted to get involved in healthcare, and I told people, here's what I'm interested in doing, they started suggesting to me, why don't you become a doctor? And literally that was how I started to percolate on, wow, could I really become a doctor? And started the whole path. So that had a huge influence on me. I was just so impressed with what they were doing, and I felt like they were so far ahead of so much of what we were doing in the U.S.
Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code Maryal20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes. For the people who are listening to this podcast, especially if you're in medical school or in residency and you do have the opportunity, or even if you're a physician who is able to, have the time to take a trip overseas to work with organizations. I mean, yes, it's a little harder with COVID, but at the same time, there's so many ways to support overseas organizations. And I truly believe, having done overseas work myself, when you speak to your experience and how the setting was, where people really have the trust in you because you're a physician, because, you're there with the understanding that you're there to take care of them. When you talk about the relaxed visits, it's like while you're talking, I can envision myself in those same visits in the Dominican Republic or in Ghana. And other physicians have talked on this podcast, Dr. Jack Forbush, Dr. Christina Gonzalez, about time overseas. And so I encourage people to, if you haven't and you have the ability to, definitely think about having that on your horizon in terms of checking out a way to serve another country and another community, because it really brings a different perspective to your life and to your way of practicing medicine.
And it really does. And two comments about that I'd like to add. One is that I think it's really important when you go overseas to see the healthcare workers that you're going to be working with and observing and all that, seeing them as colleagues and really approaching it as what a great opportunity to connect with colleagues in another country. I think that is much appreciated by them. When we did our exchange program with this community hospital in Honduras, it was really cool because we wanted it to be an exchange program. So we were going to send students and residents down there, but we were adamant with UC San Diego that we had to have the opportunity to bring up their doctors and nurses. And so we got funding for it and all that. We managed one trip for them to come up here. it was so bureaucratic and difficult to just get them into any facility to even observe. It's just crazy. But we managed to do it. One was a surgeon. We paired him up with some surgeons, and he was so delighted to be able to connect with colleagues here, and vice versa. They loved it too. Because we always have stuff to talk about. Oh, what do you do for this? And what are you guys doing for that? And oh, what's this gadget? Same with the nurses. That is really neat. The other thing I'll say about it, more related directly to DPC, is that it's so important, I think, to recognize what can be done in less resource intensive environments, because so much of what we think we need to provide healthcare is completely unnecessary. And especially if you're going into DPC and setting up your own practice or working with people to set up a practice, it's easy to get overwhelmed and think you have to have a whole lot of complex stuff and a lot of machines and like sinks in every room and all this kind of stuff, when you really don't. And I always remind people of a talk I heard of with the doc in New Orleans after Hurricane Katrina. And she was saying, look, we had to do medicine on the street corner. That's all there was. People needed care. So I always remind myself of that. And obviously, if you hang out a shingle on a street corner, people are going to come to you here. But it calms you into, like realizing, okay, what is it that people really want and need? Again, how do I respond to my community? What's going to resonate for them, and what's going to become very quickly completely unimportant?
Definitely. And I love that. And it really, again, just going back to the fact this is the opening podcast for the season, it really challenges people to think about that, especially if they haven't yet, purchased their first AndaMeds purchase or leased a space. So definitely things to think about. Now, I want to ask this question because I love asking everybody, and you alluded to it earlier that you knew that there was a better way to do healthcare after you finished residency, but how did you come to learn about DPC?
So I actually had the privilege of being related to somebody who did DPC. So my cousin Garrison Bliss, the granddaddy of direct primary care, was practicing in Seattle, and I just happened to pick a residency in Seattle. So it's just kismet, because I have never really spent any time with Garrison. We've lived in completely different states growing up. He's, a generation older than me. So even though we're cousins, he had much further along in his medical career. So he was practicing with it was called concierge at that point, before the name direct primary care was invented. But it was so great because all throughout residency, periodically we would get together and I'd come over and shadow him in the clinic, or we'd go have dinner. And I'll never forget, anyone who knows Garrison knows he's like Mr. Happy all the time. But there's a reason for that. He got out of, the increasingly stressful and unrewarding world of fee-for-service and later HMO style primary care, and moved into doing this monthly fee model, and found such joy in his practice that it kept him the bubbly, happy guy that he has always been. So imagine you're a resident, you're kind of like, oh God, I'm tired. Everyone's in a bad mood and everything, I have way too much to do. And then you're following around this doctor who you ask, so how does it feel to do this kind of practice? And he says, oh, every time I walk into a patient exam room, I feel like I've been invited to a party. And I was like, oh God, this is one of the crazy blisses. What can't you warn me? But, he just would drop these pearls of wisdom all the time. And then I'd go running back to residency and meet our valent sessions with the other residents. And I'd say, do you know what Garrison told me this time? He said he feels like he's been invited to a party. Isn't that amazing? Or just little bits of really great advice. People going into DPC will hear things like, well, how are you going to deal with the worried well or super anxious patients and all that kind of thing? And he said things like, if someone is always anxious, if someone is, or I guess like overutilizers, that's what people will say is that term. And so I've thought that too. Like, how do you deal with overutilizers? They're going to eat up all your time. You won't have time for anybody else. And he said, there's no such thing really as overutilization. There's a reason why someone is to see the doctor all the time and calling all the time, because who would in their right mind want to spend all their life hanging out with the doctor? It just is not a healthy, normal use of your time, right? Our health should be, if it's ideal, it's great, and it's in the background and we're living our lives. So he said, my job is to get to the bottom of why that is. And is this person suffering from an anxiety disorder, or do they have some unrecognized fear that hasn't been addressed? So many, I could tell you a million of these, so many of these really stuck with me. And I thought about doing this kind of practice back in medical school when he first started doing it. I learned about it. And I thought, why can we do this for Medicaid? And why can we do this for everybody? And it really is quite affordable the way that he was doing. So I really was intrigued with it, but I couldn't imagine, nobody at that point was coming out of residency and setting up their own practice. There was really no modeling of that, and there was no mentorship available. And none of us could imagine financing something like that. It just seemed so overwhelming. And a lot of folks, including, I had some debt. I didn't have a lot, thankfully. And you come out of training with a bunch of debt, it's not like you're going to take on more debt to set up a practice. So it took a while, but he then approached me a few years into my practice at the FQHC, Carolyn Downs, and said, hey, I'm thinking I want to do this on a larger scale. Would you like to join me? And lots of back and forth. And eventually I said yes. And that was the birth of Qliance. And Qliance, in the process of working with the Washington State Legislature and the Insurance Commissioner to make it legal, which was cracking me up because it's just a business. Why does this have to be given the blessing of the Insurance Commissioner? Yeah. It did. But we had to come up with a name for the model. And during that legislative session is when we made up the term direct primary care. So that's where it comes from. It wasn't called that before then. So a little bit of history for everybody. But that's how I got involved.
I love it. And yeah, that's not just how did you learn about direct primary care, but you just shared about how the movement was named. I love that.
Yeah, we gave birth to it.
That's awesome. And for those who have not yet checked out Dr. Bliss's blog accompanying this podcast, there is a recording where she goes into depth about the experience at Qliance. So I definitely encourage you to watch that recording from the 2018 DPC Summit. But Dr. Bliss, can you give a high-level introduction to those people who might not be familiar with Qliance, what Qliance was, and what an impact it has made on this entire movement?
Sure. So the dream of Qliance was to demonstrate how this model actually could be the model for primary care in this country and repair so many of the problems that were plaguing it, and bottom up, repair a lot of kind of rebalance the healthcare system, drive really good incentives, drive better care, bring the majority of the care back to primary care, which is where it belongs. So, in a whole bunch of different studies that have been done, it's been shown that 85 to 90% of what people actually need from the healthcare system can be provided in the primary care setting, especially if you have pretty robust capabilities. But our system is flipped upside down, and we've weakened primary care so much that we can't do that. So Qliance wanted to demonstrate how effective this would be. So we set out from the beginning to prove the concept. So we looked at it as Garrison's practice was the beta, and this was going to be the for real. As it turned out, Qliance was the beta. I don't know what you called before beta, gamma. Now we're terrified of all these Greek letters. But anyway, we figured we would start reaching out to individuals, and then later we realized we really need to engage with the system the way it's built. So we started reaching out to employers and ended up building 7 clinics in the Puget Sound area. We had a wide variety of customers, and the employer business became a big part of our business because employer-sponsored health insurance and health coverage is such a huge part of this country's system, and you really couldn't operate outside of that entirely. We also ended up working with a Medicaid managed care plan, and starting about a year before the ACA went into effect. And then when the ACA went into effect, it became a massive program for Qliance, covering both Medicaid and exchange plan members. So we, grew and grew actually really, really fast under the ACA, which was very challenging. But we were able to, it was a very painful process getting the data downstream to be able to show what we were doing. But we did end up being able to show that this model of care, almost naturally, by the way it was set up, drove much decreased use of downstream resources. And we never set any rules or restrictions on any of the providers saying, thou shalt not refer. We didn't really give them feedback on their referrals, like saying, here's your benchmark, and you're sending too many referrals, and it's costing too much. We just did a natural experiment and let it run out. And the minute you cut a hospital stay is a minimum, it's $2,500 a day for a room, let alone all the care. So if you prevent one hospitalization, it pays for months and months and months of direct primary care. So it was great to be able to demonstrate that. And then in the Medicaid community population, to be able to show that, it was very rewarding. Unfortunately, we ended up getting cut off at the knees for various reasons. And if you watch that presentation, you'll get a lot more information on it. So I won't belabor that here. But what I think happened in some ways is we stepped over a couple of lines that were sacred in the healthcare system, where there's this sort of agreement among our government and insurance companies and employers and everybody to keep it the way it is. Mm-hmm. And so what we were showing was pretty radical, and it really started to get some national attention. Funny enough, after the Time article came out, it was very shortly after that the Medicaid managed care companies started to turn on us. And all of a sudden they were showing us data that showed that, oh, we did a terrible job. But really it was all, they had misanalyzed their own data. And when we said, you're doing it wrong, here's the way that you need to actually look at the data, we just got nowhere. So that was the beginning of the end for Qliance, because that had become such a big part of our business. But looking back, I'm really proud of what we did. I think that it was rough going a lot of the time. It was very difficult, and it ended very abruptly and painfully for everybody. But I think that I didn't realize what an impact Qliance had really on the DPC community until a couple of years, 2018, I guess it was a year later, I went to the HINT Summit, and it was like, it brought tears to my eyes. So many people came up to me and were coming up to Garrison saying, thank you so much for everything you did to pave the way. And it was really hard, but it's been so valuable, and it just blew me away. And it really was the beginning of healing from that whole process for me, because I realized, oh, this is just the way movements go, right? And people had told me that at the beginning. We had investors and other people who would say to me, Erika, pioneers always get killed. And I was like, no, we're going to be different. I swear, I'm determined. And I had always been able to succeed when I was determined to do something. But this was my Waterloo, where it was like actually just being a little tiny company determined to overturn the healthcare system. What were we thinking? It takes a while to build that kind of movement. And that's why I might talk about tunneling through rock. You break a lot of machinery doing that. And we were some of the machinery. Anyway, I was able to pull the focus back and see, when you're building a movement, in retrospect, you look back and it looks amazing. It just unfurled and kept moving in this positive direction. But the reality is that there's a lot of pain and suffering along the way. There's a lot of missteps. There's a lot of going in the wrong direction, having to correct. So to me, to see how many people are doing DPC now and how many people look to the Qliance experience for grounding in all of this is just amazing to me.
Absolutely. And even though that recording was done in 2018, the Tunneling Through Rock session, it's really evergreen content. In that blog, there's also a concierge medicine radio interview that you did, I think 2014, but still the tenets that you talk about, the things that you're sharing today as well. This content is continuously going to help fuel and remind people of the value proposition that we bring as physicians to the table when we choose direct care. So I love that. And this is why I think I go back to that statement that you literally have been through it all. You're this phoenix in my mind. You went through Qliance, and the Qliance continues to impact the community, but then you also opened up Equinox Primary Care. So I wanted to touch on your practice now with all of these lessons that you've learned along the way and how you're operating your own solo practice now. I wanted to start with first asking, how did you choose the name Equinox?
So Qliance had to shut its doors literally overnight. It was a big drama, a big loan that was about to come through, and then it just was taking too long, and a payment that was being held by the Medicaid company, and then fraud committed on us. It was just a disaster. It reads like some novel. And so we literally had no money to operate, and it was very sudden. So we had to shut our doors, bam. And I needed to work, and I needed financial means to pay my rent and keep going. So I had to do this super fast. I literally decided on the name within a day. And I thought about the fact that I was going to be going through this enormous transition. And I thought about the equinoxes and how in human history they represent such a major time every year. And there's so many human rituals around those things. Mm-hmm. And it's this incredible transformation of nature from one, kind of a dormant stage to an alive stage or alive to dormant or whatever. So it spoke to me in the sense of being, this is going to be a major life change. And I don't know what's coming, but we're going to see.
Fantastic. And with you being the solo doctor at Equinox, do you work with other staff at your clinic?
I do. I have one medical assistant, and we work together at Qliance, and she graciously agreed to continue working with me and really has been a rock through this whole thing. It was very devoted and supportive. And I told her, I don't expect you to do this forever, but if you would help me get through the next year or two, and now it's been almost 5 years. She's been great. And she's about 80 to 85% time. It varies because we really only are in the office or partially in the office for 4 days a week. And then we have an administrative day. And typically she doesn't work on that day. Sometimes I will work a half day to cover me if I'm going to be really busy. And that's it. That's all of the staff.
Gotcha. And in the past, you have spoken about how as you grew Qliance, having more staff added on, that it was not necessarily a challenge, but it was something that you had to pay attention to while hiring, that you had people who believed in the model. So you definitely had an advantage with her understanding what direct primary care is. But if other people are looking to hire staff for their clinic, if they're adding their first staff member or they're adding their sixth, what are some words of advice that you could give to people who are selecting and weeding out those people who might not understand the core of what we're doing?
Yeah. So I think it depends a little bit on how you set up your model in terms of, I think one of the most important things is technical skills and professionalism. That's true of any healthcare setting. And I don't want to put anything in front of that. Those two things, because you can't really remediate somebody who doesn't have a good sense of professionalism. And you can teach skills, but you really kind of want hitting the ground that you've got somebody who can do the skills and the technical things that you really need. If you want that. Now, if you're going to do EKGs and draw blood and do all that stuff yourself, great. Then you don't really need a skilled person. But it might seem okay in the beginning, but then once you grow, it gets to be a bit of a distraction from the other things you want to do. It really depends. I mean, if you're doing a solo mobile clinic, the DPC model, you probably don't want to pay for someone to drive around with you, but that's another way to do it. So those things are like off the top. I would want to do it. And to me, it was important too that I wanted to continue the way we had done it at Qliance, that people were licensed medical providers who had had proper training. I'm a big believer in that. So that's number one. One of the things we eventually put into the contracts at Qliance were things like, I agree that while I'm at work or on duty in some way, that my patient's needs come before mine. And we decided to make that upfront because we wanted to make sure that people understood that's what was expected. We're not asking people to kill themselves for patients or remove all boundaries and enable people or anything like that. None of that. It was just this notion of, again, it's a concept of medical professionalism that when you're on duty, the patients come first. And if you're tired or feeling crummy or whatever, emotionally, whatever, distressed, if you can't function and take good care of your patients, then take care of your business and then come back to it. But that's a given, I think, for folks. But we felt like we wanted to say that up front. I think having somebody who's really personable, who's going to answer the phone and be present with people. And one of the things I love about my MA is that I frequently hear when she's rooming patients, there's laughter. And I'm just like, so awesome. She has a great way of putting patients at ease. She laughs about things with them. She really gets to know them. She has a very nice manner on the phone. She's just a great human being. So that means a lot. And one more thing I would say is somebody who you feel that you can be direct with. And managing people is definitely was a learned skill for me. And I can't say that I really loved managing a lot of people at Qliance. That was very difficult for me. And I realized in retrospect, I had no background in it. And there's doctors who are not generally that great at it. You have to learn that set of skills and you have to have a philosophy of it, just like anything else you would approach. Managing people is not like, it's like people with breastfeeding, right? You think, oh, breastfeeding is just going to come naturally. No, it's a learned skill and it takes time to get good at it. I think managing people is the same way. And for some people, managing people is the worst possible thing in their mind to do. And so maybe you shouldn't have staff, or you should have a service that you use and have somebody else manage that. It all depends on how you want to approach it.
A note from our sponsor, Elation Health. Elation Health is a clinical-first EHR built for you and your DPC practice. With over 20,000 clinicians, Elation allows you to focus on what matters most, providing phenomenal patient care. Ensure your patients receive high-quality, proactive care through an intuitive clinical workflow while reducing manual work and charting time. Elation Health's EHR supports you throughout all stages of your DPC journey. To learn more or request a demo, visit elationhealth.com/mydpcstory. When you opened your doors at Equinox, how was your panel? Did you start with 0 patients at day 1 and then grow from there? Or what was your experience after you opened? Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad.
So I was fortunate in that I had a core group of people to start Equinox. Honestly, if nobody had needed care at that point and I could get a little bit of money together and leave town and go to Mexico and just recuperate on the beach, I probably would have done that. It was more, I had a bunch of patients who needed care. And so I set up Equinox to respond immediately to them. It was a little crazy, but I had probably about 180 people to start. But I had their, I had records and I had all that kind of thing. And I had my assistant helping me. So that was a really great number to start with, because then you've got revenue, right? And you've got a nice stable base that you can start to grow from. So that was kind of unique, taking over a group of people from another practice, essentially.
I want to ask, with you having 180 on day 1, what was that like to manage everybody and to get them scheduled appropriately so that they got the care that they needed in a timely fashion?
So it was even more challenging than that. So Qliance had a program with the Seattle Firefighters Union Healthcare Trust, and we were doing a ton of firefighter physicals every week, and we had staff doing that at a special clinic, etc. So I said to the trust, we can keep that going. And initially, I thought that some of the providers from Qliance were going to want to come and do those with me, but they ended up deciding not to. So I was doing half my time doing firefighter physicals, which are these long, involved physicals with doing all this testing and everything. And then half my time taking care of my other patients. And then shutting everything down for Qliance. And so it was an insane time. I don't really remember a lot of it, to be honest with you. It's a huge blur. And a lot of things fell through the cracks. It was not an ideal way to start this, but it was out of necessity. And I felt a big sense of responsibility to try to maintain something. So essentially, I had more than, say, 180 patients, but the firefighter part of it was just these physicals that we were doing. It wasn't really a continuous primary care relationship. How did we manage it? It was very hectic, and we were running back and forth between that location and a very temporary small space that we had, and looking for a new clinic eventually to settle. But somehow we managed, and the patients were so amazing. They were so understanding. I had a couple people schedule an appointment just to come in and check up on me and say, how are you doing? Like, are you okay? Is there anything I can do to help you? And I was like, didn't you come see me for here? And they're like, no, I really don't need anything. I'm just checking on you. I was blown away by that they cared so much, that they cared about the relationship so much, and they wanted me as their doctor enough to come and check on me. So that was a very interesting statistic of that. So I think it's interesting now. So I recently had another doctor join me in my space. She has her own direct primary care practice, and she was very nervous about not growing fast enough. And I said, you just wait and see, because a lot of people are going to follow you from your current practice, and word is going to get out very quickly. And sure enough, she's swooped up to, 85, 90 patients in the first month and a half. And it's a little hectic. She's really having to run pretty fast to keep up with everything. And also that's onboarding a lot of new patients. So the onboarding process of a bunch of new patients you've never seen before, that is extremely time consuming and all that. So it's interesting watching her go through it, and I keep reassuring her and saying, slow down, don't worry about, you've got revenue, right? And if you're even just covering your expenses, that's fantastic. Just, you got time. And if you do it right from the beginning, you're going to enjoy this a lot.
Definitely. And that idea of keep your overhead low is echoed in so many physicians when talking to others about starting out DPC. Let me ask you there, when you looked for your space after your temporary location, did you look for a space that was including like a larger space that could be rented out to help make it easier for another physician to come join and use that space for their DPC?
So the space, I would have liked a smaller space. I really didn't need all that space, but there wasn't a lot available. It was mostly bigger than what I have now. And, you can space pocket, what's called space pocket, the space and not pay rent on a portion of the space if you don't really need it, and work out deals with the landlords where you have first right of refusal to the additional space, or if they choose to lease it out. We did that once or twice in Qliance when we weren't quite big enough to take the space, but we thought we might grow into it. So there's things you can do like that to negotiate with your landlord. But I just didn't have a lot of choice. And a lot of buildings don't want to do medical office space because it's a lot of cost to build it out. And then you've got this very chopped up space that mostly has to be taken apart unless you find another medical office. Because medical office space is, by necessity, you've got a lot of rooms and it's very closed up. And most offices, other kinds of businesses don't really want that. The other thing is oftentimes you're pulling plumbing into a whole bunch of rooms, which is very expensive, also not necessary. And the landlords don't like that. So there were very few places available at the time. And healthcare, I don't know that healthcare providers are considered such a great option for landlords either. So it was basically what I was going to get. So the building space designer came up with, I told him kind of what I wanted. And he said, we've got this much space, here's what I can give you. And it was a beautiful design. It was very functional, but we really were using it. So I tried renting out space to a physical therapist, a hypnotherapist at one point, and it was going to be this interesting thing where I had other sort of alternative type providers in the same space. But that really didn't work out to be anything really big, and it was hard to find anybody who was going to be appropriate for using that space. So the person who's in the space with me now is someone I've known for years and has sort of gradually moved more and more towards doing direct primary care, and considered a whole bunch of options and realized like coming into a completely built out space that's ready to go, that's all organized with people that get along with each other was ideal. If I had had that opportunity, I would have been delighted. In retrospect, I realized I really could have tried harder to find space within another medical office. Mm-hmm. But again, it was a very frenetic time. I didn't have a lot of time to really do the research. I didn't have the peace of mind and the calm to do it in the right way. So I think another piece of advice I would give is there's a lot to be said for being centered and calm in your approach to setting this up and not allowing anything to make you feel pressured. I got to make this decision right now. The more leeway you give yourself, the more lead time, not to dawdle and think about things too much, but to be able to really approach it very methodically and think through your options and talk to lots of people is a better way to do it. But I'm very happy with the space. Patients really love it. It's not in a medical building, which is also very nice. It was great during COVID because nobody wanted to go into any medical facility, right? And I didn't see a lot of patients in person, but when I did need them to come in, I said, listen, this is not a medical office building. It's not sick people going in and out. It's going to be one person at a time and out of the clinic. Pretty much all these businesses are working from home anyway, so there's literally nobody in this building. So it's very safe. So that actually worked out too.
Thank you so much for sharing that about your space. And I definitely would say, especially if you have the ability to reach out to other DPC physicians in your area, definitely reach out to them to discuss, if they have a space, how did they come about their space? Because like other physicians have shared, there might be a realtor that they use who was very knowledgeable in negotiating contracts or, things like that to help you find an ideal space. And that's so important in terms of when you feel like you're being rushed into something. I definitely would say it's important for anyone to pay attention to that feeling and really work out where that's coming from. Similar to how you talked about Garrison, finding out like where the anxiety comes in patients when they contact the doctor all the time. So important. Now you have a full panel. So how do you look back and say, okay, this is how I knew I was full?
So I grew a lot during COVID. And I think I heard from other DPC practices that they did as well. And for various reasons, I think we could theorize that was the case. But I grew by probably 100 patients almost in the year of COVID. And I didn't really realize it at the time. And then when I looked at my numbers, I was like, God, that was really fast. And I felt it, right? So it was all the stress of COVID and all that kind of thing. And it definitely I felt pressure. So when I got up to about 440 patients, I realized like that's enough. I can't take any more patients. So I closed the panel. And also by that time, I had taken on a couple of other activities. I'd taken on a new activity, which I can talk about, and I was continuing to do a couple of other things that I do on a volunteer basis. And the need started to really increase for those services during COVID. And as I sort of got caught a little bit with taking on the activity that I took on once COVID had started was doing medication abortions by telemedicine. And there ended up being this tremendous need. And there was a lot of work to do in conjunction with a whole bunch of people in this country and internationally to get that off the ground. And so I was really excited about that and got really involved and was doing all this stuff. And meanwhile, I didn't really notice that my patient population was growing as fast as it was. And at some point, I just was like, whoa, this is going to be a bit much. On top of that, all of our emotional and psychological and physical distress under COVID and all the other political upheaval, social upheaval, environmental upheaval going on, it's been such, I don't have to tell anybody listening to this because we're all part of it, what an intense time that was. So I realized when I was feeling a little too stressed, I was working on weekends consistently to catch up. My days were going long. I wasn't leaving the office on time. And I was getting kind of irritable sometimes and those kinds of things. Those were all my signals that I had gone too far. And so I sat down and I thought, what am I really enjoying doing? And I was like, I'm really enjoying primary care still. It's a tough time to do it just because everyone wants answers to everything and it's all in process. And, it was just, but I realized I really loved doing the medication abortion work. And it was very grounding because it was such an immediate service. And it was just like boom, 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 And it was just so gratifying and people were so grateful. And it was just an incredible community that it got me involved in. So I said, I'm going to make sure that I carve out enough time to do that and some of the other things I want to do. And I also want to learn finally in my life. I'm 54 years old now, so this is starting at age 52. I said, darn it, I want to learn how to have balance in my life. I want to focus on family. I want to do other things. I want to feel refreshed. I just want all this other stuff that I never took the time to do or develop. And I've always loved working. I love my work, so it wasn't hard to just devote all the time to that. That's when I really said, you know what, I'm just going to let it dwindle. Because, of course, the minute you stop taking patients, your numbers start to go down. People die. A lot of people died during COVID for various different reasons, not of COVID in my practice, but elderly people developed cancer, all kinds of stuff. And so people moved away or got some other coverage and decided they didn't want to continue, all the usual reasons. So I've let it dwindle down to just a little over 400 now. And that feels good. And I just watched myself during that process to see, like, where is it that I start to feel like, okay, my schedule still has openings all the time. I don't feel stressed. I can take time off during the day to go do other things and appointments for myself to get my eyes taken care of. Or get physical therapy that I needed. I was like, oh, it's not a big deal if I carve out 2 hours of the day to go take care of myself, or go meet up with a friend that I haven't seen in a while. Go for a walk. I got a dog, right? So I need to like train my dog and all this other stuff. So I don't want to be working till 7 or 8 at night. I want to finish at 6. We see patients from 10 to 6. I'm not a morning person. Set it up so that it actually made sense for me. So those were all of the things. So now sometimes I have a week where I'm like, God, there's nothing on the schedule. Maybe I don't have enough patients. But then I remind myself, I still have the same number of patients. The revenue is the same. And it's going to pick up. This is a slow week. Wait a couple of weeks. Inevitably, you're going to have a crazy week. I mean, crazy in DPC world is not crazy. So those are all the kinds of things that I looked at. And I really paid attention to my mood and my emotional response to things. And did I have the time and energy to stop and think about what I was doing? And to remain really engaged in the dialectical relationship between myself and patients, myself and my staff member, myself and my family. So to make this be a really interesting time of growth rather than just like slamming roll.
It makes me think about when Dr. Jalon Burton and I were doing her interview. She told me how she has to put specific time on the schedule to network with other DPC physicians. And I was like, I had never thought about that. And then I looked at my schedule, and with this podcast and just with talking about DPC while planning my own, it was like, I realized how many hours I was spending just all over the board with networking conversations and being friends with the idea that you have autonomy and that you have the ability to look at balance and figure out what that means for your life. It's such a different place to be compared to in fee for service when you are, you're here at these hours to these hours, and then you have to chart in your pajamas, and then you barely get sleep, et cetera, et cetera. So that's so important for people to think about in their own practices when they're growing and when they decide to stop their panel growth.
And I schedule everything. And I put things on the patient schedule. We have this really nice system, and I think we can talk about what systems I use if you'd like, but a really nice system that makes scheduling and reshuffling the schedule so easy. And so I can on the fly block out some time, or I can do it ahead of time, and it's easy to put stuff in and out and block out certain types of appointments and all that kind of thing, so that I can create flexibility on the fly, but I can also go ahead, and I've gotten much more confident about just taking time and scheduling it out and doing other things. Everyone does fine. Get the patients taken care of. Almost never am I not able to see a patient when they need to. It just always seems to work.
Yeah.
I think of being at the right number is, what have you promised to your patients? Have you promised same or next day availability? Have you promised that you will be available for, I don't know that anybody would do this, but available for non-urgent things, and you'll meet them at the clinic on the weekend. So then the question is, are you meeting the expectations you've set with your patients? And if you're not, or if it's a struggle to do it, then you need to adjust something. If you have too many patients or you set the wrong expectations, and I've changed, I promised a lot more to my patients than I needed to early on. And then when I realized that they're not really using some of this stuff, and it doesn't mean anything to them if they never need to access that particular aspect of the service. So why am I even doing it? Setting clear expectations. Instead of getting angry with people because they bother you on the weekend, quote unquote, for something that can easily wait till Monday, and then feeling like, what is wrong with this person? Why would they do this? I realized I had set up expectations, and I'm always available to you. Whatever you need, just contact me. And so, of course, they did. And then they were surprised if I wasn't unhappy with that. And I had to sit back and say, it's not their fault, it's mine. Like, I set up the wrong expectations. So that was a really big piece of growth for me, is that when you just tell people what they can expect of you, and you watch yourself to make sure you're meeting those expectations most of the time, give yourself a break if it's not perfect, people are very happy with that because they know exactly what to expect of you.
Absolutely. Boundaries are so important, especially when you, like yourself, are a solo doctor, when you don't necessarily have multiple layers of staff to deal with patient questions and patient refills, et cetera, before they get to you. So it definitely is so important to keep in mind. If your expectations or your boundaries that you've set up for your patients are that they have access to same or next day care, that could be in the form of I'll send you a portal message or an email or a text or whatever it is, because it's still care. It's still coming from you. So I want to ask, because at Qliance, you guys did not have what we have now with all of these multiple EMRs to choose from and ways to communicate with patients. So what tech have you found really, hones in on your ability to provide care for your 400 plus patients?
Yeah, you hit it right on the head. When I think back to our experience with tech in Qliance, we opened in 2007. And Garrison used to say, we should just build an EMR. And everyone said, you're crazy. I'm like, we didn't build an EMR. Anyway, so we ended up with a commercial EMR that, really did not do what we needed to do. It was funky, and it was probably one of the better ones and more accessible ones, but also very expensive. It's funny if you look at all tech and you think, of course it was like that. That's where it wasn't just healthcare. Like software just wasn't what it is now, and you couldn't have the same expectations of it. Now, healthcare was further behind, but nobody had what. So I really appreciate you making that comment, because nobody had what we really needed, and we were super frustrated about it. So we ended up actually building an EMR. So we started with a piece of software that had been started to be developed by a guy in the UK who was brilliant. But it was quite an ordeal building something. I actually think that what we built was, it was essentially a prototype for what I think would have been a really great system. And we thought through all the workflow issues and all the data that you need out of it. And I would have loved to really be able to pursue that more, but eventually we had to, when Qliance closed, we didn't have the opportunity to keep doing that. So now, and I'm not a paid sponsor of any of these companies, but I will tell you who's and what I think of them. So I needed to put something together fast. Again, the theme of my setting up Equinox was fast. The first thing I did was I called up Zach Holdsworth at Kent. Zach and I had known each other from the beginning. He's just a wonderful, I can't speak highly enough about him. He's just such a great guy. And I had been formally advised him as he was setting up Kent. We would talk all the time. He was very attentive to the needs of everybody in the DPC movement, and he built a really nice piece of software. So there was no question for me about where to go from the practice management software. So then I didn't even know how to set up a website or do anything, and Zach walked me through it, and we were like, chop. Literally within a couple of hours, I had a website. It was hosted. He helped me with my logo. It was just amazing. What a wonderful person. Anyway. So then I went to Kent and I said, what is it integrated with? That was a big plus. So I'd seen Relation software before, and actually we did a little advising for them when we were with Qliance, and I thought, this is perfect. This is what I need. It's missing some of the bells and whistles I would love to have, but I can totally live without them. And I didn't have the same big company needs as I had with Qliance. So I picked Relation, and then needed scheduling, and I wanted patients to be able to schedule themselves. And at the time, Relation didn't have that. So I went to IntakeQ, which is not integrated with the other systems, but is a very easy system to use. And I still use that to this day, even though it's disconnected from, I've linked it to Hint, and I've learned more about how to drive people directly from from sign up all the way to making an appointment, getting the forms they need using IntakeQ. And then I just recently started using Spruce, which I really like. So I'm a latecomer to Spruce, but it's been great. I'm trying to think what else I use. And we're probably going to switch over to video conferencing on Spruce as well. Right now I'm using DoxyMe, which I really like. But eventually the cost of all of this add up. So if I've got another video platform I can use that's integrated, I'm just going to go to that. And I think that's pretty much it.
With you having the tech that allows you to have your practice the way you want it to be, that allows, your patients to get the care that they need, and now you have a practice that allows you balance. What does the balance in your practice allow you the time to do now?
From my days working at the community clinic, I got trained to do forensic medical exams for asylum seekers. So I've been doing that since, 2004. And I don't know how many of them I've done over the years, but I probably do a couple a year on average. And that's a volunteer service for this network that helps connect attorneys to providers who can do the medical or psychological evaluations. I've always really loved doing it, even though it's often very sad and very kind of disappointing to think about humanity and how terrible we are to each other sometimes. But at the same time, you are really helping someone. It's a short period of time that you have to devote to it. And then the forensic part of it is super interesting. So over the years, I've gotten more and more into that, the notion of learning about how do scars heal and how do you confirm or not that a particular injury described by someone who has been tortured, would it look like this or not? Does it fit? Does the story fit? And can you say, more likely than not, this scar would happen if something like this happened to them? And sometimes they've been very minimal ones, sometimes it's been really kind of in-depth, I had to really think about, wait a second, how do these things heal? I almost never write my report right away. I absorb and think about it, because the forensic part of it, you really have to think about how do things heal and what would you likely expect? Because oftentimes it's years ago. By the time they're in the asylum process, the injuries are quite old, several years. So that's really the end of life that I do under the death with dignity law in Washington. I got involved because of a patient of mine years ago who asked me to help. And I learned through that case about an organization in Washington called End of Life Washington, which is one of the premier non-governmental groups, nonprofits in the country, supporting people who want to take advantage of these laws to end their life in a dignified manner. It's now called Medications to Aid in Dying Me. So I started doing that several years ago. And initially, actually, as I was building my practice and money was a little bit tight, I had to charge for them. I would give it I would do it as a donation if people really didn't have any means. But for the most part, I was charging people a fee for being either the attending or consultant physician. When I got to the point where my practice was doing okay, I stopped charging for it, and it's just a purely volunteer thing now. I do a lot of those cases because there's a very big shortage of doctors. It has to be doctors who will do this. And half of the healthcare systems in Washington state are owned by Catholic institutions, so they can't. So it's a huge need in the state. Those were really more intermittent, but the medication abortion work that I got involved in actually has become a daily part of my routine. So every day I work with several different organizations, and I also have patients come directly through my practice. I just work it into my schedule. Now we have a pharmacy that can ship for us, so I have to get all my orders in by noon, otherwise they can't get them out that day. So if I have new orders that come in, new cases that come in later in the day, I just generally wait till the next day to do them. It's very organized. We have a great set of teams who handle a lot of the intake and the review and all that. So by the time I'm addressing the cases, except for my own, which I do start to finish, it's not a heavy lift, but it's super interesting. It's very specialized. It's just first trimester medication abortions, but there's a ton to learn. And there's a ton of great people involved, and it's all virtual. Like, I've never met any of these people that I work with to do this. And it used to be a ton of meetings and planning and all this other stuff, and now it's running really, really smoothly. Now, there's always something new, and of course, abortion is under attack in this country, so there's plenty to do. But we've also brought on a lot more people into this community, so I no longer am having to do the bulk of the work. There's lots of other people involved. So those three things are hugely satisfying to me. And the medication abortion work I do get paid for, but they're very inexpensive treatments. I only charge $150, and half of that goes to the medication. So it's not like it's a big expensive thing and it's a lot of money, but it does bring in some revenue to my practice. I donate a certain amount of cases as needed, so nobody gets turned away, which is what I do in my practice too. So if my patients fall on hard times, they can pay whatever they can until they feel like they can. And it's up to me to figure out financially what I need to make that practice work. So as the medication abortion work grew and became a piece of revenue for me, I just looked at my revenue and thought, okay, then I don't need to keep growing the practice, back to our other discussion, because I have this. Now, I remind myself, what if this went away? Or what if I still have a contract with the firefighters to take care of a small number of folks with them through a third party. What if that went away? What if that program ended? I got to be ready. What is that chunk of revenue that if it went away, what would I do? So that's a really important thing. So it's great to make time for volunteer work and all this other stuff. As long as you're thinking ahead, yeah, that's nice. But what if this chunk of revenue fell away? Am I prepared for that? And not just, I'm going to slam really hard and work really hard. No, I don't want that lack of balance. I want to know that I'm comfortable enough so if something happened, I'd still be okay.
When you talk about being prepared, do you have I'm set for paying my daily expenses and paying the clinic overhead for 6 months? Or how do you set it up so that you feel financially comfortable, so to speak, if something were to drop off your plate that was no longer bringing revenue in?
I think in general, the business world's recommendation is have 6 months of operating expenses tucked away. So I definitely have that now, and it's so much easier now that I have someone else sharing the space with me because my cost just dropped by half. I mean, I was carrying a very expensive lease up until now. And so having that cut in half, now I have reasonable rent. But up until now, it was hard to save money because I was pouring a lot into a lease that was just way more than I should have ever taken on. Again, I didn't have a lot of choice at the time. I had a lot of stuff to pay back and things to deal with as well. So it's really only this past year that I've been able to start catching up on that. So I would say now I have that money in the bank. It's also a matter of predicting there's certain things like, what if something terrible happened to me? I got hit by a bus and I was incapacitated or dead. My lease becomes invalid. Mm-hmm. Or now this other doctor can take it over if she wants to. So I realized, there's certain things I don't have to feel responsible for. If you die or you're incapacitated, your lease can be annulled, right? So that takes care of that. Bummer that my assistant would have to go find another job, but I've made a commitment to paying really well. So it's up to her to save for her future and have a buffer herself. It's not my responsibility. I'm not taking it on. I haven't promised her big severance or anything if something happened. So I didn't, again, expectations. I haven't set up a lot of expectations with people that I can't fulfill. It was a big learning from Qliance is don't promise a lot of stuff that you might have trouble. So the 6 months in savings, super important, making sure you're constantly trying to keep your expenses to a minimum. And then I always tell people, think of the absolute worst case scenario. What is the literally worst thing that can happen? And then what would you do? Mm-hmm. And then you get real about it and you're like, it's not so bad. I mean, the biggest issue would be someone closing down the business if I couldn't do it myself. And if you have 6 months in the bank and everything goes haywire, then you've got some savings. But I think that the bigger picture is, discipline yourself early on, as early as you can, to put money into savings, to put money into your retirement, to not get too excited when the practice starts to make money and start spending more money. That's the time to really crank down on your expenses. Say, I'm doing well now. Now let me take that money and put it into a good investment in my future of some sort. And I've not been great about that in my lifetime. I'm kind of learning that lesson late, but it feels really good to do that.
If you are talking to somebody who doesn't necessarily have a lot of patients, or they're opening out of residency in a new location and they're not known, so they work their first, couple months with 5 or less patients, what do you suggest to people in terms of when to take a salary?
So I think the easiest thing to do starting out with 0 is have some other job that you can do. And don't worry about not being sitting at the phone 8 hours a day, 5 days a week, ready for your patients. With our modern technology, there's so many ways to be, quote, available to your patients without having to be just sitting there. So you could actually be doing other jobs. You could be doing shift work. You could be doing all kinds of different stuff to bring in some revenue while you build your practice. Even to the point of saying, my practice is just beginning. I'm going to be open 3 days a week, and then I'll be available for messaging other times. Or I'll be available 2 days a week in the clinic and the rest of the time virtual or whatever. So having some other source of income as a doctor, you're so in demand, and there's so many jobs out there. There's jobs you can do. Like a friend of mine became disabled early in her career, so she now does utilization review for one of these companies that does hospital utilization review. It's all remote. It always has been.
Yeah.
And so you can be home reviewing charts and doing that kind of stuff. So you have to be creative about the other work you can do. I would highly recommend that because then you can relax. You've got the revenue. You're just not putting money down the tubes. And if you can find a small space to have a presence or do mobile only, as I know some people have done, that's ideal. And then in terms of taking a salary, what I've done for quite a while is I just, I in my bookkeeping, I just say owners paying personal expenses over and over and over again. I didn't really bother to make myself an employee. And then you just make sure you pay into Social Security and Medicare and all that kind of stuff, which at some point you have to anyway. The government makes you do that. And I think that's how I handled it. I didn't really need to make myself an employee for a reason. I got health insurance through the exchange. That was actually cheaper than putting myself on my employee plan because of my age. There's lots of different things you can do like that. If you have a spouse, you can be on their health insurance plan, and that makes sense financially. Yet another reason to not bother making yourself an employee. So that's kind of how I've done it.
And one thing I just want to put here, especially for people who might be new to the podcast or who are exploring DPC for the first time, is if you are going to take a job to support your DPC, definitely pay attention to the non-compete clauses and if they're enforceable in your state, because multiple physicians have talked about they have to practice so many miles away from their previous practice, or in some states like California, it's not enforceable. So definitely an important thing to figure out if you're planning DPC for your future.
The other thing too is don't forget some residencies and medical schools need preceptors. And if it's paid, then you could do some precepting. And those are fairly short shifts. So usually half a day or something really fun work to do. I never did that myself, but I know a lot of people who've done that.
Awesome. So going back to the fact that you have been there, done that, seen it all, and you're still thriving as a solo practitioner, I want to ask, when you think about the movement, what could you say to other people in terms of when they're talking to people who don't know about direct primary care yet, or they don't have the tools to understand really how to do it? What is the way that you would challenge people to potentially talk to those fellow physicians and say, hey, this is what to think about if you are really looking for another way to do care?
Let me think about that, because I have talked to so many people since the beginning of Qliance about this particular thing. What I say to people is, don't think of DPC as this Shangri-La. You're going to step into a new world and it's going to be perfect and everything's wonderful and goodbye, etc. It's work. What we do is work. We take care of people. Healthcare it's just a difficult endeavor because think about all the stories you just hear from people. Incredible stories, good, bad, and ugly. And you carry that with you no matter what you do. I'm not talking about in an unhealthy way. I'm saying we are the confidants of so many people at good, bad, and mediocre times in their lives. And the thing that I think is so great about DPC is that human engagement it's unbelievably rich in a way that I don't know because I'm not in fee-for-service and I only did 3 years in fee-for-service in a community clinic setting. But from what I hear from my colleagues, it just sounds unbelievable how not like that it is and how difficult it is when they do establish and maintain pretty deep relationships with their patients. I think of that as being a miracle. Whereas in DPC, it's just routine. It's routine that your patients, that you know what's going on with them, that you're connected with them, that you are involved to the level you need to be involved at any given time. And that you grow and you recognize you're growing from the experience as well. I talked about the dialectical nature of the relationship. But like anything, you get out of it what you put in. And giving up working for somebody else to working for yourself is a transition. I wouldn't have it any other way. I'm not great at working for other people, and I think a lot of doctors aren't actually. And you take on managing all this stuff. But I think the key is if you go into it intentionally thinking, what is it that I truly believe I can deliver? Set those expectations of yourself, communicate those to other people. When it doesn't work, make adjustments. Everyone has a right to change their mind at any time in their lives. I'm a firm believer in that. So if you realize that with DPC, you create your reality, you create your future, it makes it so much easier to deal with all those frustrations of the healthcare system that you will have to deal with. Prior authorizations, referrals, bad things happening, all that kind of stuff. You still have to engage with the rest of the system. It's just that you are not being paid by that system and driven into the ground. So those would be the main things I would say to people. There's huge reward. And if you're willing to put in the work and take on the responsibility. But it's not a heavy burden. It feels light because you are getting so much satisfaction out of this incredibly privileged way to take care of people.
Beautiful. Thank you so much, Dr. Bliss, for joining us today. It was such a pleasure.
My pleasure. I really enjoyed it. And kudos to you for doing this. Your whole approach and what you're doing for the community is just tremendous. And I really applaud you for that.
Next week, look forward to hearing from another amazing DPC physician. Now, I looked through the stats for the podcast since it started, and the data is beyond incredible. My DPC Story is ranked in the top 0.15% of all podcasts on the globe. Yes, the globe. Every single month over the last 2 seasons, we are ranking in the top 250 of the Apple Podcast Medicine chart every month as well. If you would like to join us in helping spread the word about DPC, consider sponsoring the work we're doing. Go to the sponsorship tab at mydpcstory.com or check out the link in the show notes. Now, to our listeners, thank you so much for helping more and more people find the pod by sharing the word about DPC. To our guests, thank you so much for sharing your stories. If you are looking to be a guest next season, apply on the contact page at mydpcstory.com. There you'll also find DPC swag, past episodes, resources, and more. And as always, if you're looking to read more about DPC on the daily, check out dpcnews.com. Until next week, this is Maryal Concepcion.